Size effect.
Yes. So the principles that are applied are used, for example, centration, the use of the central nervous system, its progressive control of the body, craniocaudally, the observation of fixed and mobile points. So if I want to mobilize the shoulder, for example, how do I, in a closed chain position, the fixed and mobile points are switched. My hand position and my direction of forces are different. In an open chain position, they are switched and my vectors are applied differently. I have to know that, and it will depend again on what my goal is and what I'm trying to achieve in restoring centration and integrating the appendage to the canister, and vice versa, integrating the canister to the appendage. So these are what comprise the second part. And then the third part allows us to look at fundamental movements and what we expect.
Just to kind of say, and for my own information as well as everyone else, you said it, you are in this second course, you will test the chains. That one statement does a lot of lifting, because the provocative testing of the muscle chains for you and I, there are a lot of tests done in a variety of positions to ensure that the patient has the capacity to feel these chains and to provide either resistance, significant tone and resistance of these chains. And then there are concomitant treatments for each of these chain tests. So this is, and this these chain tests is really a key thing that you came up with, that it answers the question that, again, a lot of DNS people eventually have, which is, okay, you've given me these developmental positions. I understand we use them as exercises in rehab, but how and when do I pick positions? And how and when do I use the positions? Prior to the chain tests, it's difficult to say, okay, well, for this case, I would use high oblique sit, and I would have them do it on their left side in this way and resist this thing. And on the other side, I would do it in this way and I would resist in an opposite direction. There really wasn't a good way to answer that question, but the use of the chain tests really directs the rehab. It is what individualizes the care to the particular patient's problem. So going back to your conversation with that guy, what you mention? His name was Lieben something.
Craig Liebenson.
Yes. I think I've heard of him. I think before. Your idea that if we could only have a step-by-step thing to identify the real primary kind of movement dysfunction, then we can hone in on the primary rehabilitation. We can say this is a turning problem, and where you've taken it further is not only is it a turning problem, but it's a anterior aspect of the oblique chain going all the way down to the knee turning problem to the left. You've really made it very specific and honed it to where, okay, well, now I am going to use DNS positions of turning to the left and facilitating this particular aspect of a chain. And all of that was encompassed by you saying, yeah, by the way, in part 2, we test the chains. I didn't want to skip over the fact that is very, very vital and important, and takes a lot of the time in the part 2 course, is learning the provocative chain tests.
Yes, you're right. I think that the chain tests do cover locomotion and turning aspects and homologous aspects, because the chains remain the same throughout. They are just different fixations of the chains that are required. And if the brain cannot find these fixations, then the patient may fail in one position and yet pass in another. So that was always the many times when I started out, I was fooled by the position. I thought, well, if you can pass this position, you should pass that position. If you can pass this chain in this position, then it should be strong in that position. And I never could wrap my mind around why a chain would be strong in one position, but weak in another. And as time went on, you started to realize that the establishment of fixed points anchors the chain. Failure to establish the fixed point in one position, but success in another, determines whether you can use the chain or not. It is not just whether the chain is strong. That is not really the problem.
Is the chain strong in just space, or is it when you, I mean, you said
Yeah, that's right.
When you establish differing support points in different positions,
yes,
even though
you
it's
have
the
access.
same chain, it's different, completely different function.
That's right. So access to the strength of a chain is dependent on the efficient fixed point establishment. That is really what is required. And that was what I concluded with, realizing what a challenge it was to try to hone in on what would help one patient and another, etc., and why there might be confounding findings in terms of testing until you realize that you were trying to wag the dog by the tail and that it wasn't going to work that way. So that is really it. And the DNS principles, which are then used for manual therapy, help you to really prepare the tissue in line with the developmental process. It is really sad that many times you will hear people go, well, we don't move like babies. But no, we don't move like babies. But the same principles that have allowed us to watch two species act in a particular way because they have a commonality in origin, or they have a similarity in their evolution, and allows for prediction between the two, is the same way in which the human movement is linked to child development. We must respect the fact that even though my bones have changed in structure and the relative segments have changed, and that the use of these chains are modified and allow me much greater repertoire in movement, there are underlying basic similarities that are linked by the central nervous system because it's the same brain, just developed, and by the fact that the tissues themselves, although they are modified, are still genetically what they were in terms of origin. So it is an arrogant thing to dismiss that link, because we're not claiming that we move like babies. We're claiming that the program that allowed babies to move allow us to move now, because we have used elements of that program to develop the repertoire we now have. And so that is really what the software, I know, we update it based on the original, we just like software, you get the original software and then patches are added to it over time to update it for new challenges. So yes, I don't expect to see a baby do a triple axel or or land a 6 pirouette process. But
well, you can demonstrate that at the next C course. You'll do this.
Yes, if the ambulance is standing by. carry me quickly to a resolution.
How'd the seminar with Robert go? He left in an ambulance.
He left early after the first demonstration. It was awful. He was screaming. So this is really it, you know.
Yeah.
So
if you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.